our pilot study about the mother and baby-friendly hospital initiative. We call it the hospital initiative, but indeed it's called facility-based, because we have several kinds of facilities, birth centers, and so on. But in Brazil, mostly of them are hospitals, and we are working this into to public hospitals there. And I will try to wrap up some of the concepts that we have worked in these days in this presentation. So the project is called Strategy for Incorporating Innovation in Childbirth and Newborn Care, Pilot Innovation in SUS, which is our public health system, of the hospital-friendly for women and children initiative. So we have, I have highlighted some of the concepts that we have gone through. So the idea is that in recent years, many innovations have been proposed in perinatal health to make it safer, reduction of morbidity, and what we have discussed it, the idea of harm-free care. How is it possible to make care safer, reducing harm related to the kind of assistance that we provide? So we very much want to measure and to monitor harm and to promote harm-free care. That means that we are counting as morbidity the effect of care. This is a quite different approach to what we were doing. And the idea is it would be based on evidence through the use of protocol and the idea of informed choice. So as we have discussed it before, we are bringing this evidence, as we have talked about, is at least 20 years old, and trying to put it in checklists like your famous Indian author, about the checklist, Atul Gawande. I strongly suggest that those who didn't read his book, at least the one on checklist, because he wrote so many interesting books. We are using his concepts of checklist, very useful ones here, including we can do checklists of informed choice. We can have protocols of informed choice, and that they are less aggressive. Less aggressive meaning dealing with how we identify rights violations, especially in the issue of relational dimension, but also related to how intervention themselves can be aggressive. In the medical jargon, sometimes aggressive is good, There's aggressive management of some conditions, And indeed, you need the so-called aggressive management in some circumstances. The word aggressive is a bit aggressive, okay? You could be active or proactive or something. We can even use a better word. But the idea of aggressive has a role. Thinking about the words, because we think about the surgical armamentary and so on. The words are the weapons. It's very bellic, okay? But for physiological care, it's not necessarily we need aggressive care, okay? Unless you have a complication. So we are rescuing the concept of innovation that we have discussed. It's the idea of a technical change. And the technical understood here broadly as a new way of working. We were talking about the kangaroo care. Remember, we mentioned the issue of kangaroo care. And kangaroo care was previously something that was used for the poor, for those who didn't have that. And now it is the gold standard of care. New way of working, the health promotion or the prevention of disease. And as we were talking earlier this morning, considering the perinatal period as a very strategic window to prevent disease in the long term. The issue that if you have appropriate contact of the baby with the maternal microbiome, you will have this healthy microbiome profile in the offspring, preventing disease in the long term, which will have an effect of the epidemiological situation of a given population. I put also these the men with kangaroo in the scale with kangaroo, because the idea is broader, not kangaroo mother, but also kangaroo father, kangaroo family, and so on, to challenge us to think outside of the box about how gender issues inform our practices and how we can go a little further, including men and families, in terms of care of the babies and so on. So the characteristics of public health innovations and in nutrition also, the characteristics are the requirement of interaction of several entities. And this is very interesting because I will repeat this many times, but there is no salvation outside. I don't know if this English is reasonable, but you know, there's no way we can solve the problem outside of regulation. We need regulation for this, you know, including for the issue of innovation. Sometimes we cannot innovate because we have excellent ideas, but they are not implemented because nobody regulates what is done. So it requires the interaction of several entities, including government, university, research centers, labs, etc. I'm showing you, can you see what is this picture? Please see what you are seeing. Tell me what you are seeing in this picture. Come on, people.
It's an incubator.
It's an incubator. What else? No, this is a baby in a hammock inside of the incubator. Can you see the hammock? Yeah, this is the baby leg here. This is the hammock. And the baby is inside the incubator in a hammock. Have you heard of this? It works very well. It's amazing, you know. For some reason, babies put more weight, that's less infection, and so on. It a bit simulates the uterine environment, or is more comfortable. Whatever is the reason, you know, this is because in Northeast Brazil, people, as I was telling you, the way you don't have beds, instead you have mats to sleep on the floor. The Northeast Brazil, because of our native Brazilian used to sleep in hammocks. You know, everybody is in hammocks. So in Northeast Brazil, sometimes you find no bed at home because people all sleep on. You can even have a bed, but people sleep on hammocks, you know. So it's part of their culture. So for some reason, people invented to do this, and something that's very cheap, etc., and helps babies thrive, you know. And it frequently demands the use of interdisciplinary and intersectoral strategy, because you need interdisciplinary research to do, for instance, a clinical trial comparing one thing with the other. Because there is so much emphasis today in the study of the first 1,000 days of the baby, there is also renewed interest on doing interventions to protect these babies who are more vulnerable and so on, and this is one of them. So some of the characteristics are the emphasis on the organization and process intervention rather than on products innovations like patents and so on. So I always showed you this picture. This one. Remember? So how many innovations you can see in this picture? Let's resume this. This one. Companionship, position. I can hear. Mode of delivery, yes. Supporter, you have a doula too, isn't it? So this does not demand any extra resource, training, mindset, but not anything extra. No extra cost, for instance. Nothing, just changing people's mindset and position. So you have, as you said, the systematic review by Ellen Hodnett that I showed you yesterday, you have all kinds of better outcomes for mothers and babies, as you saw, from APGAR to, length of delivery, with very simple interventions, And in this picture that you can see here, this one, have you ever seen this? This is in almost all public hospitals presently in Brazil. What is this? Have you seen this?
It's a Swiss ball.
Yes, it's a Swiss ball. Yeah, physiotherapy ball.
Pelvic muscle training exercises.
Yes, for Pilates or, some forms of yoga, people use this. Yes, physiotherapy in general, isn't it? So you can find that in maternity services. It's a very cheap resource. And this is someone, the person who is with the laboring woman is her mother, who's not a trained provider, It's extremely comfortable. There are clinical trials showing how comfortable it is in labor for counter pressure during labor. So these are very cheap resources that can be used if you have a mindset that thinks about women's comfort and so on. This can be done within the maternity ward. These things are very simple. You don't need even extra place for doing this. Birth anthropologist called Robbie Davis Floyd. I don't know if any of you ever read her. I strongly suggest reading her. She has a wonderful book called Birth is an American Rite of Passage, where she describes birth as ritual, and each of the interventions a formal ritual. It's a masterpiece, her book. And she's very much inspired by another anthropologist called Bridget Jordan, who wrote another masterpiece called Birth in Four Cultures. And it was this book. Bridget Jordan is called the midwives of the anthropology of birth. Because she helped give birth to this area called the anthropology of birth. And everybody used to go to exotic place and study the exotic people's birth, And she did this, but comparing with the Western birth, she studied also U.S. and the Netherlands and the Inuit. So she compared Mexican, Inuit, and with the American and the Netherlands, and compared everything. And she concludes that all people need rituals, for this. And she described the irrationality, because comparing the U.S. with the Netherlands, it's very interesting, because in the Netherlands, they have this culture of medicalized birth, etc., with midwives. In the U.S., by that time, it was she studied the 80s, much more medicalized than it is now, showing that we all have rituals for dealing with birth, and some of them are very irrational. So Robert Davis Floyd wrote the whole book to explain the irrationality of not using evidence. So what is the reason why we don't incorporate evidence? What's the reason why some forms of care are so irrational? They are detached from medical rationality, divorced from this rationality. So she calls for a broad idea of technology, and she calls the jacuzzi as a form of technology. So I'll show you a form of technology, which is the jacuzzi, You have jacuzzi here. Okay. So she says that jacuzzi is a form of technology. This is very interesting, because this image that I'm showing you is from the Sophia Feldman Hospital, which is the hospital I was telling you about, which is a very innovative hospital. And they have births in the jacuzzi for the last 15 years for the poor, you know, so for in their setting. So I've heard many people here say, "Oh, but this is so dangerous here in India." In Brazil, you know, this is more or less gold standard. There are good systematic reviews about this, about safety and so on. Any technology from a jacuzzi in the hospital to a children's pool in the house, you know, nothing is exempt of risk. Absolutely not. You can say this is riskless. It doesn't exist, you know, but according to the systematic review, people have very good outcomes. And some people choose it because it feels very comfortable. But the idea is that it needs to have an impact in health indicators. So we have to study them, we have to measure them. I will strongly suggest for those who want to know more about Brazilian health system, and it's being very much threatened by the recent government. We are in a very difficult situation in Brazil now. But I will suggest strongly for those who want to know more, reading this paper that's called Health Condition and Health Policy Innovation in Brazil, The Way Forward. Because it's this idea of innovation as policy making as innovation. And that's very interesting because this is by a Brazilian author called Cesar Victor and his colleagues. And he says, the challenge is ultimately political, and we conclude with a call for action that requires continuous engagement by Brazilian society as a whole in securing the right to health for all Brazilian people. This is especially important in days like the days we are having today. But this is extremely positive to think, I will call you public health people of the future, you know. Think out of the box. Think in solutions, you know. It's so necessary that we try to imagine potential solutions for our settings, you know, considering this situation, the situation that we have to do with. And regulation is something that is so extremely important. So I will show some of the issues about innovation, and here are some of them. Well, as I said, innovation not necessarily related to market gains, but to population well-being, and can be triggered by several issues like emergence of new problems, social pressures, improving living conditions. I will show some of their results from social movements in Brazil. This one is related to the right for companionship. This is a campaign called A Father is Not a Visit. Because in Brazilian hospitals, you have a time for a visit, you know? The visit has a limited time that it had to go through, you know? It used to be from 3 to 5 or 2 to 4, something very limited, you know? So this is to grant father 24 hours of access to hospitals, you know? It was a campaign for people to follow because this is in the law, you know? So they put this, and they even uses, how to say, buttons, etc. Father's not a visit, you know? So that fathers could have free access. And the other one is, that means the present that makes the difference. All pregnant women have the right for companionship during childbirth is the law, you know, for people to, sometimes, although we have the law, the provider would say, I'm the law here, I'm the one, no, I don't. Or some would say, oh, I know there is a law, but we don't have privacy. We don't have, or invent some kind of limitation. The companion can be there, but just for those who had the training. The companion can be there, but just for the husband. The companion can be there, but just for female. The companion can be there, but just for adults. The companion can be there, but just for adolescents. And they kept inventing limits for companionship. It has nothing to do. All women have the right to a companion for her choice in full time. So this is the reason why we need checklists, you know. The companions need food, the companions need a place to stay, the companions need, you know, there's all set of things. And the service can say, but we don't have funding for this. So we have to lobby for funding, organize for funding, plan for funding, and so on. It's not easy to implement change. It demands, you know, a lot of effort. And social movements make all the difference, because we need social movements to be up to date with the evidence and use evidence to promote change. We need social movements to go to the streets to demand change. We need social movements to write a law proposal, lobby for the law, approve the law, and afterwards, if the law is approved, you know, make the law happen, campaign for the law, implement, you know, go to the justice against people who don't know. So we cannot retire from activism, you know. But this is very interesting in terms of change of the culture, because 20 years ago, we almost had companionship was a privilege for those who could pay extra for having a few hours to be there, you know. Presently, if you don't allow the companionship, you're in trouble, you know. It happens, but it's you risk being in trouble. And that's what we tell everybody. There are many ways to change the culture. For instance, we used to do 10 years ago, to write to the service and say, oh, respectful service, you are so important, so good, etc., so respectable, etc., etc. I'm communicating you that I'm, according to law X and X, I'm taking my companion, and the companion will be there. So register that you send the letter. Make sure that someone received the letter, and so on. So it takes so many different initiatives to change the culture. And finally, we used to say in Brazil that doctors have difficulties in related to patients, you know? Relating to companions are whole other things, because providers feel watched, you know? And they're not very comfortable with this. So you have even to change training and helping people be comfortable with this and to accept this and so on. So these are major changes to implement innovation. The other thing in terms of innovation is that innovation can be an investment or can be a disinvestment, you know? I will show you, this is the campaign of the Parto do Princípio network. Yeah. Campaign for the abolition of looking at episiotomy. You know, it's years and years and years of this campaign. This is another campaign against episiotomy here. This is episiotomy scar. And this is a photograph exhibit, very beautiful one that I was telling you, called 1 in 4. This is one of my favorite pictures. This is a woman saying that she told the doctor she didn't consent with the episiotomy. She sent this in written form that she didn't consent. And in time of birth, the provider did the episiotomy anyway, you know. And this is the scar that she has of this episiotomy. These are two other campaigns. This one up here says, respect the time for your baby. For birth, there's no holiday. Avoid elective birth. Choose adequate birth. Adequate birth is an initiative of the private sector in Sao Paulo, you know, because, as I told you, in 2006, this network of women, the Parto do Princípio network, they went to justice against the private sector because the private sector did not allow women to have evidence-based adequate birth, you know. So they said they are not following medical rationality. They don't respect safety, and so on. They had a very well organized campaign, but a legal action indeed, based on medical rationale. And so the judge that have never thought of this had to put the women, lay women, men of the lay into medical terms, because they were very well informed lawyers, and some of them were judges, and they were very prepared, to face the doctors of the medical boards and medical schools. They were very prepared to say, you're not providing evidence-based care. And they were using the systematic reviews to do this, So one of the things that they demanded is that they provided midwifery care, because doctor's time was very expensive. So they said, we cannot provide a doctor to stay for 12 hours, 8 hours to follow your birth. No problem. Get midwives. If the doctor is there, if the doctor thinks that he has to be, because the doctor is very important in the, he is the chief of the team. It's no problem. Let the doctor be there. So they hired midwives, and it's been a very important success, So this is the poster of this initiative that was started with this women's initiative. The INS up there is the agency that regulates medical practice in Brazil. And this last one here is a advertisement of a package for childbirth, and they say we offer a room for you, we have companionship, etc., and we offer 1 day of neonatal intensive care. Okay. Because it's a C-section, elective C-section, so the risk of needing one is very high. They already includes, So this is for telling you how important is both investment and disinvestment. For instance, there are some technologies to be included and other ones that be withdrawn. But relactation is something that I'm so enthusiastic about this, and people sometimes never heard about it. When a woman has a insufficient milk supply, or she's adoptive mother and wants to breastfeed, you can do this, You can formula and start giving to the baby with the small cannula, attached to that. In 2 weeks, you are producing all the milk. It's amazing. And you know that an adoptive mother can do this, right? So we have a program for women when they are in the line for adoption, and the baby will come in 1 month. They can start breastfeeding, relactation for breastfeeding. It's very interesting. So I have 2 friends who adopted, and they breastfed because, how discovered this? They discovered this because in Africa, in some regions, in times of the crops, women had to go for the crops. The mothers who were breastfeeding, they would give the babies to other women, their mothers, and put the baby in the breast. And so they would produce milk again, Sometimes a woman who never breastfed. And there are these very interesting studies of the undernutrition in Africa. They decided to admit the baby and the mother together to breastfeed, to relactate the mother, And of course, it was the best outcomes, So this exists, works wonderfully, and we have a training program for this. This is called the lactation consultant, and they can do this kind of wonderful thing that people get. It's jaw-dropping because people don't even believe that this exists, but it exists, works very well. It's really amazing. So you can mobilize resources that would be wasted and replace it for lower alternatives like formula. So this is very much health promotion, because breastfeeding is very good for the baby, prevents all kinds of non-communicable disease, and for the mother prevents obesity, diabetes, cancer, etc. So this is really primary and tertiary prevention. So this policy exists, and there are pressures of the women's movement. In some times, they are being very slow. It's the case of changing, like in having this negative impact, like abuse of cesarean section, preterm birth, health problems with breastfeeding, violation of women's and children's rights. So there's this what we call in Brazil humanization, that demands evidence and implementation of rights. And this is the reason why we have this initiative. I'll tell now about the proposal and the indicators we are using. So we are using the international initiative that I showed to you before, and the indicators that we have for mother-friendly and baby-friendly initiative is freedom of movement during labor and having access to light food and beverage, non-discriminatory policy, privacy during labor and delivery, women's choice of companion, cultural competent care, without physical, verbal, emotional, and financial abuse. In case of Brazil, in the 2 hospitals, we have free care. No routine practice, no unconsented care, pharmacological, access to pharmacological and non-pharmacological relief for pain, and skin-to-skin contact between mother and baby, and encouragement of breastfeeding. That's a very important part of the project. We are timing everything, you know, timing the first minute, trying the first hour, etc. So the project objective is to develop. So to develop is going to be a huge part, but also to evaluate. So these are different issues. This pilot project for the implementation of the initiative into training maternity hospitals in the public sector in Sao Paulo, in the other cities called Ribeirão Preto. This is a training setting, you know, where the people are very surgical-like, but assisting it. Nothing of this. This is interesting because nothing of this necessary in the setting. Masks and this kind of clothes. And so this is to tell you that we have a very successful in Brazil baby-friendly initiative. And in 2014, there was an appendix of them that's called the Mother-Baby Initiative. So we have the international initiative that was run by WHO and FIGO, etc. And we have a national one that was made 1 year before that's related to our baby-friendly initiative. So in terms... Yeah, it's federal government, yes. In terms of methodology, it's a quasi-experimental design, before and after design, with mixed methods. So we have a qualitative step. That's where we are finishing now, you know. Observation of service, interviews, and focus group to study how professionals and managers perceive abuse in care and their relation to the precarious conditions of working and training. So we are also getting baseline information, hospital records, and interview with postpartum women, and regular service information, all interventions to track their frequencies, pre- and post-intervention. So the hospitals have good tracking of the intervention, but the one in Ribeirão Preto developed very innovative new indicators. We are amazed. We are learning so much from them, you know, and they are very good on informatics skills. They build a very, very sophisticated program for that. So we want to have a very dense qualitative component and a dense quantitative component. We're going to use... I keep telling my colleagues with this because we're working also in the team. We have an anthropologist and we have several other professionals, and we already have so much material. We could start by now, but this is just the part to prepare the intervention. So the intervention is in 3 aspects. It is a participatory approach on priorities and indicators and how to monitor the indicators. So people are very much involved on this. We are working together with the group. We're going to have a training on updating for managers and professionals on evidence and rights. It's a whole training program. And then training service with simulation of daily situations, referring to technical and to relational routine. So we have the issue of simulation for the situation that they identify as problematic. And we will develop educational material for accreditation of the initiative in collaboration with the Reproductive Health Library of the World Health Organization. And we want to form a generation of qualified providers for accreditation. We are very pretentious, We want to form a whole process for accreditation for this initiative. So this is more or less the project. It is now because it's a working process. We are now finishing the first step of what are the main problems in both services. From now on, we are redesigning everything about the intervention that will start in March. This project, it goes until July 2018, so we are in its first semester. Obrigada, that means thank you.